the jungle. It is perhaps a jungle. Dr. Weber, he talked about radio-chemoembolization. So it was a mix-up of radioembolization and chemoembolization. Perhaps in reality, these are competing things, but it may be a jungle sometimes. It's a difficult field. We have heterogeneous patient populations. There's a variability in techniques, and there is a limited number of randomized studies. With a local treatment, we aim to destroy the tumor, to improve survival, and we have to limit the damage to the remaining liver tissue, but also to the patient. So this is the principle that governs the decision in the clinical practice to do something. We can destroy the tumor by several means. I will not go into details, but we can inject ethanol. This is safe. The drawbacks are this is only valid for small lesions, but you need multiple sessions. There are new needles that you can inject more alcohol in a lesion, like you do it with radiofrequency ablation. So there are new devices coming because ethanol is cheap. Even if your government taxes ethanol, it's still cheaper than doing some electrical or a difficult device. But you can use other needles now to do this, and the studies are underway. Acetic acid has been tried, but there are less sessions needed than ethanol, but the thermal damage is now the most appropriate way of treating a small HCC lesion. The advantage of the ablation by RFA, it's not ablation, in fact it's destruction, you don't take it away, it's a destruction of the tissue, is that you have a margin of at least 0.5 to 1 centimeter surrounding the lesion to kill all the microsatellites. And it's not the case with ethanol. Just remember the basic pathology of HCC. A small nodule, less than 1.5 centimeter, is most of the time well differentiated. When you are above 1.5 centimeter, you already have some zones of less differentiated tumor and some satellites surrounding this small lesion. So the lesion in the second case, in the first case of 2 centimeter, I look to this already as a potentially dangerous lesion. It's not small, it's a lesion of 2 centimeters. When you have a polyp in the colon of 2 centimeters, it's huge before your scope. It's a big lesion. The liver is big. And so you have the impression that it's small, but it's really cancer. And there are several studies that have shown that RFA is better than ethanol, also in terms of survival, but especially in terms of local control. Remember the margin. Drawbacks, you cannot do it in every patient, RFA, because of vessels that are cooling the zone of intent. It's less effective in lesions larger than 5 centimeters. And there is a problem, perhaps, of needle track seeding. The literature has been, in the beginning, high in the report of 10% of seeding, but this number has coming down in recent years. So seeding, especially when it's in percutaneous procedures more often, multiple sessions, but the technique is evolving. Ablation of the needle track is helping preventing seeding. Microwave ablation is a new kid on the block. I have written also a text that in the syllabus should be there with some overview, but Roberto Lencioni did a great job in one of his reviews to summarize these new techniques, but they are there and studies are busy. An important issue is you can eradicate a small lesion, but what is the problem? That nearly all of these patients will have a distant recurrence in the liver. So the main message of this is when you have one lesion, it's only the prelude of new lesions that will appear. It's a victory, but it won't last for many years. So HCC is an organ disease. The first nodule is a prelude to others, and therefore always liver transplantation should be in the beginning of the decision-making process in your head, especially if you have access to liver transplantation. The transcatheter treatments are very popular. The transarterial chemoembolization, studies have been done. We know when you have a response, you will do better, a complete response, no vascularity on dedicated CT or MRI, you will have a better response. But a very interesting paper earlier this year showed a radiological, histological correlation of patients on the waiting list that, first of all, the images that we do in a patient on the waiting list, and we have a short waiting list and so reliable imaging prior to transplant, you are only correct in 57% of the cases. You have understaging in 38% and overestimation in a minority. So the amount of necrosis in the tumor and the number of lesions and so on, we are not so good in predicting this on the current imaging. Even if you use modified RECIST and so on, the radiological, histological correlation is bad. The outcome, and that's more interesting, complete necrosis, you can have it in small lesions. In 15% of lesions, you have a complete necrosis, whatever you do with local regional therapies, either RFA or TACE. And you have an excellent survival also following transplant. If you have only partial necrosis, you have a significant drop in survival. So we should aim at complete necrosis, not partial necrosis. We have several techniques, and we know if you use the beads, the drug-eluting beads, whatever the type that they are, you have less systemic exposure of chemo and you have less side effects. It's probably as efficient, but you will not kill your patient due to side effects or bone marrow suppression or whatever. Embolization alone is not enough. We know it already from Dr. Lovet's paper from in the 90s, that you have indeed a benefit of chemo adding to just the embolization, and this has been suggested also for the spheres. We cannot TACE everybody, only Child-Pugh A patients, a patent portal vein and a hepatopetal flow, and a tumor size less than 10 centimeters. But there is a high incidence of recurrence because of angiogenic factors that are upregulated after this procedure. There are strategies that we can stop this angiogenic mechanism. We can use sorafenib and so on. Unfortunately, a very big promising trial, well conducted anyway, was negative. And so for the time being, we should not combine TACE with sorafenib, for the time being. What is an issue? You do TACE, but should you repeat the TACE? And there have been now an ART score, the Art of Decision Making, a very nice title in this manuscript from earlier this year, that you can, after one TACE, with a small score, increase in transaminases, additional points in the Child-Pugh score, the lack of response. Well, you can decide whether you will go for a second TACE or not. And if you say it's enough because your patient is not going to benefit, you have to look for other approaches. So this is the way to go forward, when to call stop to a certain therapy. And then the super selective TACE, very promising approach. And what is really important from these studies is that TACE is not effective in small lesions. So when you have a lesion less than 3 centimeters, you don't have as much necrosis as you would have in radiofrequency ablation. So TACE is good for lesions between 3 to 5 centimeters. So when you have treated a patient and you see a complete necrosis, you have small lesions that are popping up, I'm not sure that by not repeating, in fact, the TACE, you will have no benefit because the small lesions that were there were not initially responding to TACE, but may respond when they are a bit bigger. You need a vessel to have your beads in the tumor. And the smaller the vessels are, the less able they are to really have access, the beads have no access to the tumor. Combination of TACE and RFA, there are studies have been done. The quality of the studies was limited. We lack studies to really say we have to sequence first TACE and then RFA. There is a rational, there is a benefit, but it's only in a meta-analysis of poor quality studies. And then the big hype of the radioembolization, I will make a very long story short. It's a complex procedure. You need internal logistics that are beautifully organized because you can really hurt your patient if some radioactive particles are going to the stomach and to the lungs. So you need some good quality control. You have resin or glass beads. The difference is probably very limited. And these are the beads that are present really into the tissue. These are not parasites, but the remaining beads in a patient who got radioembolization. There are side effects. They are limited. It's not a post-embolization syndrome as in the classical case, but there are some potential side effects even in experienced centers, and you may have GI ulcerations which are very difficult to treat in expert centers also. The survival problem, these are registry data. We don't have randomized evidence that it is better than TACE or that it is even better or comparable to sorafenib. Although these registry data suggest this is not randomized evidence. Retrospective studies suggest that it is at least equivalent radioembolization to TACE, but we will need a trial of more than 1,000 patients probably to see a difference. So all the trials that are looking into comparative intermediate stage HCC with TACE versus radioembolization, I don't think currently they have the power to show a major difference. And the registry data show that the results are interesting, but of course these registry data are a bit selected and are not the quality from like a SHARP trial or whatever. So in conclusion, Mr. Chairman, for the early stage HCC, with everything that we know, local ablation is safe and effective for patients that do not qualify for a surgical procedure, especially a liver transplantation. There is an important distal failure rate. You can start with RFA, but you should think about transplant to consolidate your result. In patients who are not candidates for transplant, you may start in an early stage HCC with that. So ethanol is less advisable, but in small lesions it's as effective. And combination with TACE is investigational. And the adjuvant sorafenib study, STORM, we will have the results, and Dr. Lovett can comment on that, not for this year, but it will take a while. Intermediate and advanced HCC, the standard of care is still TACE, and I think because of safety issues, DEP-TACE is probably the best way to move forward. And in advanced HCC, we should think about sorafenib still today, even when there are competing issues like radioembolization. I've listed this on this slide, and you can find them back into the handout. And I thank you very much for your attention.